Do you have one to talk from?
Okay. So I want to talk to you guys about a couple things. And if I said to you the words evidence-based practice, evidence-based measures, or value-based purchasing, do you know what those things mean? Anybody?
Evidence-based practice.
What's evidence-based practice? Tell me.
It's where they've actually done different things to make sure that you're going to have a good result at the end.
Exactly. Who was the first person who really drove the idea of evidence-based practice? Florence Nightingale, right? Because way back in the war, what did she say? She said, we're fixing all these soldiers who are injured and everything, but they're all dying. Why are they dying? So she looked at things like good sterile technique and washing their hands and all that kind of stuff, and basically did her own kind of research that said, this is the best way that we practice. And really everything we do in nursing is driven by evidence-based practice, right? So, they do studies, they're usually done by physicians and that kind of thing, and they say, these set of patients seem to do better that had this type of care. So now, in this era of kind of the Affordable Health Care Act and that kind of thing, what Medicare and Medicaid look at is that they don't want to be reimbursing people for giving care that really doesn't help improve an outcome, nor does it help prevent them from being readmitted, right? So we're very much under the gun for our dollars. So when the Joint Commission looks at it, they say, well, there is a certain set of practice that makes patients better. So if you look at a patient who's come in with an acute MI, they say that this patient should receive this standard of care. This is really what they need to receive while they're in here. They don't need a whole bunch of other fluff. They need this standard of care. And if you give them this standard of care, the chances of them having to come back for the same problem are really low. So what we're going to do is we're going to track and watch and see if you're giving your patients this standard of care. If you don't give this standard of care, then we're not going to give you your reimbursement. So that's where you get evidence-based measures or core measures. And in your packets, there's a lot of different core measures. And the reason I kind of brought this up is because we're on a neural floor. So there are very particular things that they say you should do for a post-stroke patient or a patient who comes in, rule out stroke. And if you're not following these particular standards of care, then it's going to affect the reimbursement the hospital gets. And it's not all about the money. Don't get me wrong there. Because what this is saying, we've studied this, we've looked at this. If you do these things for the patients, that's what's best for the patient. And that's really our goal, is to do what's best for the patient. But again, it gets into that. Medicare doesn't want to spend a bunch of money on unnecessary tests or anything like that. And they want to make sure that when we send patients home, they don't come back. So if you look in your packet, you'll see that there is a list probably halfway through that talks about stroke. So there's outpatient stroke, pneumonia, go a little beyond that. Stroke. So stroke has to do with the kind of care they get in the ER. When we talk about stroke, what's the golden hour? If I said golden hour, what would you think that is?
3 hours.
The golden hour.
First hour.
It's the first hour.
Yeah.
In the first hour, we expect that a patient who comes to the ER is going to get their labs drawn, they're going to be seen by a physician, they're going to get their CAT scan done, and we're going to decide whether or not they're going to get TPA. Where does the 3 hours come in?
That's how long they can get TPA?
Right. That's where, if the patient comes in, we go by the last seen normal. So from the last seen normal till 3 hours later is when that window of when we can give them TPA if they're not a hemorrhagic stroke. So Joint Commission tracks those things. They want to make sure that we're giving the best care we can to our patients. So they want to see that that TPA is started within that 3 hour window. If the patient meets certain criteria, you can stretch that window to 4.5. But they have to be young, they can't have certain disease processes, that kind of thing. But they're still looking that by the time that 59 minutes has come up, that golden hour, that TPA is going if it's appropriate for that patient. That's their golden hour. They want those tests done and that TPA going. So we're doing a lot of training with our physicians in the ER, because what aren't they? They're not neurologists, right? So it's very scary for them to give this medication that has a lot of complications, you know, there's bleeding risks and all that kind of thing. But we really want to make sure, you know, if you're following the guidelines and they fit the criteria, you can give this medication and give it safely, because their chances of having a better outcome from giving the medications are better than if you don't. So we're going to take on the risk that they may bleed versus the risk that they're going to have severe neurological deficits.
Mm-hmm.
So we do give you some tools. You have in your hospitals, a lot of the hospitals, and I know in all the Morton Penny's hospitals, you have PCLs, patient care leaders, and that's really what they do. They track and make sure that the patients in the hospital are getting the core measure care that they're supposed to get. So they're tracking the stroke patient. Have they had their dietary consult? Did they get their statin? Do they need whatever? So they're looking at all those things that are required based on the core measures that Joint Commission sets. And they're calling the physicians. They need an order for dietary, their BMI is 32. Those kind of things. We have an evidence-based practice nurse who works in our hospital who also tracks all those things. And what her job is that if there is a fallout, it's her job to go find out why. So if this patient didn't get their TPA started in their 3-hour window, and they seem to meet the criteria, then she's gonna go find out doctor and say, why wasn't this done? So, and it might be something that's documented in the record that she missed or something like that, but that's her job, is to make sure that we're meeting our core measures and that kind of thing. But we do provide you tools, and a lot of the places that you'll work will provide you tools. So in our stroke packets at Morton Point Meets, you're gonna find this sheet, and it's on bright pink paper. So if the patient comes in through the ER, or you call a stroke alert on the floor, in the stroke packet, you're gonna pull this paper out, and this gives you your checkup, and it will say on the hard chart, and it's just a guide. But it tells you, what do you need to be looking for to make sure is done for your patient. I found, pardon me, at St. Joe's, they had a paper also, which I don't see here, that also was kind of a checkoff idea, and it showed all the things for acute MI, and I might have left it over there. But it was the same kind of idea. It showed acute MI, and it said, you know, do they have their ACE, their ARB, their statin, those kind of things. So use these when you're in practice, because somebody's going to come to you when you have your stroke patient, and they're going to say, did you do this? Is this done? They're going to call. Did they get this done? Are the neurochecks being done? That kind of thing. So, because we want to make sure, you know, it's important. If we don't get reimbursement, they close our doors. 70%, I think, of the patients that come through the hospital are Medicare or Medicaid. So if you think we're not getting reimbursed for 70% of our patients, then we're not getting reimbursed enough to keep the facility open. So that has to do with why these are important. So we talked about evidence-based practice, and we know that's kind of what guides our care, and the measures are what Joint Commission looks at. But if I talk about value-based purchasing, what does that mean? Anybody know? So if you look at this really pretty red and green sheet that I gave you, this is a chart of all the core measures that are tracked at North Bay. So you can see green is good, red is not so good. But if you look here in this middle part under JC CMS core measures, this is all the core measures that are tracked through CMS, okay? When you look at the top, it says value-based purchasing indicators. These are the ones that they say, if you're not matching these indicators, 99%, you don't pay your reimbursement. And 99% is really hard to get if you're a small hospital like North Bay and you have one fallout. So if you look at this sheet, it says here under prophylaxis, antibiotics ended within 24 hours overall rate. It's the skip indicator number 3. We had 19 times it was supposed to happen. It happened 18 times, which made us 95%. So that one indicator, one missed opportunity, made us fall below the 99%. Now we are at risk of not being reimbursed for that case. Now if you're a big hospital like Morton Plant and you give 300 antibiotics in, say, a month period, you could really miss 3 opportunities before you would even get starting below the 99%. But again, this is what affects our reimbursement, and that's where the value-based purchasing comes from. So when you hear those terms on the floor, you know, of core measures and evidence-based practice, you understand why it's so important. One of the other things is your documentation. If you don't document it, it's not done, right? That's the same with everything. Rumor has it that one of the things that's going to move here from where one of the what the Joint Commission is tracking to what the Joint Commission is going to stop reimbursing us for is VTE prophylaxis. So if you don't document every shift that your patient has their STDs on, or that they refuse them, they're going to count that as a fallout. It's a missed opportunity, and if you have enough of them, they won't give you your reimbursement. So there are a lot of things that you're going to do as you start your practice, and you're going to maybe get pushback from the physicians because physicians don't like it when people dictate their practice. But they're pretty much on board because they understand the importance of all of this. But you may be calling the physician and saying, hey, so-and-so's in here for stroke, I don't have any VTE prophylaxis, do you want me to put on some SCDs? So those are the kind of things that are going to come into play when you're doing your practice at the bedside, okay? And again, you're going to get those harassing phone calls from infection control to make sure your central line's being cleaned properly and the dressing is changed, or the evidence-based practice nurse who says, this patient isn't on a statin, why? And it's okay if they're not on a statin, but you have to say why. It has to be documented in the medical record somewhere why. So, let me just make sure I hit everything that I wanted to talk about. So when we look at the domains, the value-based purchasing is based on these top domains up here. These, I think there's 8, 7. These here. This makes up 70% of the value-based purchasing. The other 30% comes from HCAHPS and avatar scores. And what are they looking for in HCAHPS and avatar scores? What's the key word? Always. And always is the only one that counts. So if you're not meeting always, and you're falling in your 30%, it's all, again, affecting your reimbursement. And it's not, again, about the money. It's about making sure we're giving the appropriate care and good care to our patients. But again, our doors don't stay open unless we have money to pay the staff and buy equipment and stuff like that. So again, 70% comes from here, 30% comes from those avatar scores. Now I work in a hospital where the patient population is extremely challenging. We live in Pasco County, we have a lot of drug problem. Getting those always scores seems to be nearly impossible, but we do everything we can to make sure we're giving our patients appropriate care. So it can be frustrating when you hear month after month after month, we haven't met our 60th percentile, we haven't met our 60th percentile. But what we look at is we came from 30th percentile and we're now 53 percentile. So we maybe haven't met our 60th percentile, but we're going in the right direction. So don't be frustrated when you hear constantly at your team meetings those scores and numbers and you're not getting this or you're not getting that. Kind of look at the direction you're going. So, and again, like I said, we track all this stuff in the hospital. We do a lot of stuff for follow-up. We have, at the Morton Plant Nieces, we have 4 nurses who make follow-up phone calls for all the discharged patients who are discharged home. And what they're looking for, do you have your prescriptions filled? Do you have your follow-up appointment for your physician? Do you have a way to get there? Because what are we trying to do? We're trying to decrease their risk of being readmitted. So we want to make sure that we're following up with patients after they're discharged and getting that information and giving them, sometimes they have questions. Sometimes it's like, well, they gave me this medication, I really don't know what it's for, can you explain it again? Sure, it's a great opportunity to do re-education. And then when they get that survey that says, did they tell you about the side effects of their medication, then they're gonna be able to say yes. So, any questions? Does it make sense?
Yeah.
Yeah, it's very, like I said, it's very important to your practice. You're gonna get very familiar with these things. I have a stroke unit, I have a post-cath unit. My stroke unit doesn't need this checklist to go through to say what that stroke patient needs, because they're so used to taking care of those patients. They know what those core measures are. My PCI unit knows what their acute MI patients need when they're going home. So when you get into your departments and you've kind of been there a while, you'll get used to it. But if you float somewhere, you should be familiar, just kind of with, what is expected. And if you don't know, and you kind of say, oh, I remember Ann talked to us about those core measures. Is this a core measure patient? Go talk to your charge nurses or your patient care leaders and say, is this a core measure patient? Is there something I need to be looking for? Because it is really important.
I was just gonna say, like, in our hospital, and, East Bennington, we have really strict, like, policy to look for the SCDs.
Mhm.
Like, they really are interested, like, looking for SCDs, if they have them on or not.
Yeah.
If they're refusing or not. If they're refusing, you have to, document it and tell the nurse that they're refusing it, so she can contact the doctor
Yeah.
to, get another way of prophylaxis, like
Right.
DPD.
And again, it's in the documentation. You can't hold a patient down and tie their SCDs
No.
on and put crazy glue to leave them on, or rubber bands, or whatever you think you need. The patients have a right to refuse therapy. All you need to do is document that they refuse, and you are still falling within your core measure, because again, you've offered them what is best practice. If they don't want to take it, that's their right. So you can't force them, but it's true, they're very, very closely watched.
If they refuse it, do you have to document that you re-educated them on purpose?
I would just document, explained importance of SCDs, patient refuses, doctor aware. That's all you need to write, and that covers you. But again, you have to write it every shift.
Yeah.
So if you write it and then you come on and they still refuse, you have to just document that. Patient still refuses, doctor aware, educated, and whatever. Okay? All right. You can take those papers with you. They're a good guide. Put them in your backpack so when you start your careers, you'll have them and there'll be quick reference. It's a nice kind of summary of all this information.
Thank you.
Thank you.
Thanks, guys.